Before we have our panel discussion, we wanted to share with you some of the data that we've collected from all of you over the last 2.5 years. And just building on what Dr. Singer was saying, hopefully when you look at this data, you can think about what kind of stories the data is telling you and what kind of teams were developed as a result of having to collect and look at this data, and what kind of strategies the data might suggest in terms of what worked and what didn't. We've already talked about the goals of the pilot. I think we're all pretty familiar with those, so I'm just going to skip right over them. The achievements of the pilot are, as you know, we've seen some really improved care for diabetes, high blood pressure, depression, and preventive health. We've seen decreased readmissions in some areas. We've seen widespread assignment of patient panels to residents and use of population health dashboards. And as Dr. Singer was talking about, we really think that this project has started us on the path toward revitalization of the spirit of primary care, along with all of the other initiatives out there to really bring primary care to the center of a high-functioning healthcare system. The data that is being analyzed right now is being analyzed by our data analysts. Some of you have talked with them before. I'd like them to stand up, and we can acknowledge Kate Bliss, Dana Schiffman, Eva Thomas, and Jackie Matson. They've done a fantastic job. They have posters out in the poster session, so as we go through these, if you'd like more details about any of the data. So just to start with PCMH recognition, as you know, that was the main milestone at the beginning, and 100% of the sites were able to become recognized as high-level patient-centered medical home sites. And they were able to do that even if they started out, as many of them did, with no recognition at all, although there were a good proportion that were already recognized at some level. When you look at patient-centered medical homes across the state of New York, if you look over to the right of the screen to 2014, you'll see that essentially hospital medical home is responsible for the majority of the growth in patient-centered medical home providers in New York State over the last year. Being able to communicate across sites and with providers as a huge challenge in this project, and we still, of course, have lots of challenges with our electronic health records, but we have some great achievements. 97% of the sites made changes to their EHR, and 82% now have interoperable EHRs between their hospital and outpatient sites, and 96% connect to the RIO from their outpatient site, which is far above the rate seen in other clinics in New York State. In terms of clinical performance, as you know, all of you started collecting data about how you were doing, and we saw great improvements there. Breast cancer screening from 47% to 60%, colorectal cancer screening 48% to 59%, nephropathy testing for diabetics, and all the diabetes care measures really improved. Weight and physical activity assessment for children and adolescents from 58% to 86%. Et cetera, et cetera. There was really only one measure when they analyzed it that did not improve follow-up after hospitalization for mental illness within 30 days. And we don't know the reason for that, so we'd be interested to hear from you during the Q&A or from panelists your thoughts about why that might be. Resident continuity was an area that there was all kinds of innovations that occurred: PCMH electives, PCMH curricula, patient panels, chronic disease registries, improved July handoffs, rapid cycle PDSAs, as we heard before, so that residents could complete their PDSA within 1-2 week ambulatory block. At HHC, they had the specialists, residents develop referral guidelines that could be used by primary care to improve access. There's an enormous amount of innovations that we'll see in the poster session, so I hope you'll take time during lunch to look at those. We saw, in terms of the quantitative numbers, that percentage of resident visits with patients on their panel was 55%, 54% patient visits with their assigned resident PCP. And we saw some correlations with increased continuity leading to increased performance measures such as better performance on lipid control and breast cancer screening when patients saw their own PCP. Similarly, 89% of sites have now assigned their patients to a team. 91% have assigned patient panels to residents. Really, there's been a huge change in resident continuity over the 2 years. Some clinics had no team assignments at all or weren't even measuring it, and really were able to realize when there was a problem and do something about it, and there was really great improvement. These are very complicated slides that you can look at the poster session, but just to give you an idea of the analysis that we're doing on the enormous amount of data that you all have been providing to us. Dana Schiffman is working on these and can describe them more, but essentially we took each of the care integration projects and took the individual components, which is each of the colored lines, and looked at your performance on those, but then also made them into a composite measure and looked at your performance overall over the course of the project. So this is improved access and coordination between primary and specialty care. And you can see that there was some significant improvement over the course of the project, some more in some measures than others. For example, average rate of all referrals that are made and not completed really decreased. We can talk more about this at the poster session, but the decrease at the end, Dana referred to as senioritis. Care integration with physical and behavioral health had really dramatic improvements over the course of the project, probably the most. From the composite score went from 40% to 73% over the course of that project. Enhanced interpretation services for culturally competent care, also, as you can see, dramatic improvements. And care transitions and medication reconciliation, which was the most popular project that people worked on. It's something that you're all working on in many different initiatives and for CMS, for Medicare. All of these align with each other so that these are often meaningful use measures that people were working on as well. And finally, medication reconciliation, which was part of the care transitions and medication reconciliation project. And that was the most rigorous data that Kate Bliss has been analyzing, where we collected from you medication reconciliations on discharge, and she developed a study that she'll tell you more about to have a control group and really look at whether medication reconciliation at the outpatient site after discharge makes a difference to readmissions. She looked at all-cause readmissions and found that if they did not have a medication reconciliation, there was 1.5 times the odds of having an all-cause readmission compared to patients who did have a medication reconciliation. At one of the site visits, I think at Mount Sinai, they suggested we look at PPRs, or potentially preventable readmissions, to see if there was still a relationship. She did not find a relationship. At this time, we're only looking at 2013 data at the department, as that's all we have, and that's really only a year into the project. So for 2014, we may see a relationship between PPRs and medication reconciliation. I think I went the wrong direction here. Okay. And then in terms of ranges, we just wanted you to take a look at some of the areas where we saw a lot of variation and see if that was something that you could give us some comments about what might have caused that. For example, BMI assessment, the range among sites in the project was from 7% to 100% of sites assessed BMI. Similarly, breast cancer screening from 3% to 94%. Could be issues of data collection, could be population issues. So we'd be interested to hear your comments on why there was such a large range. Finally, we did a PCMH survey among the residents. We know many of you did, and we'd love to see the results that you were able to get. Our PCMH survey was sent to all the residency directors, and we had about 1,000 responses. Greater New York Hospital Association helped us develop and administer the survey. We got about a 20% response rate. In general, most residents were familiar with PCMH. Most were involved in PCMH activities at their site. Most agreed that it was really happening and that they thought it was beneficial for patients. And about 40% of those who responded said that they would like to work in a PCMH after graduation. And our experience at site visits was that residents really did communicate that they, yes, continue to be frustrated with the EHRs, but that they love team-based care, they love the coordination, and that they really appreciate working with case managers, patient navigators, and outreach workers. So I know I went through all of this data very quickly, but these slides will be posted on the website if you'd like to look at, along with your fantastic final reports. And then you can also talk with everyone at the poster session about it.
Thanks, Marietta. So what we have teed up for the next part of the conference is really a little bit more conversational. We invited 3 folks who've been involved in projects at their hospital and also been leaders in a lot of the advanced primary care patient-centered medical home for quite a while to talk publicly about their failures, as Dr. Singer mentioned. Yeah, I didn't tell you about this? Actually, we want to talk about have them share their experience and their reflections about the project from their point of view, and also think about things going forward. So very briefly, their bios are in your packet, but just very briefly to give you an idea of who you're looking at. Tom Campbell is the chair of family medicine at the University of Rochester School of Medicine and Dentistry. He's based at Highland Hospital in Rochester. There were 2 sites that were involved in the project, about 37 residents total, 24 in family medicine and internal medicine, pediatrics as well. The projects chosen included integration of physical and behavioral health, sepsis, CLABSI, and the sites and the program has a long history of providing collaborative care, depression care to adults over many years. Joanne Gottridge is the Executive Director, Vice Chair of the Department of Medicine at North Shore-LIJ. She's an Associate Professor of Medicine at Hofstra North Shore-LIJ School of Medicine. Their project involved 1 site. They have